Bem, boa tarde. Meu nome é Hamilton Cabral de Menezes Filho. Eu sou médico assistente da Unidade de Endocrinologia Pediátrica do Instituto da Criança, do Hospital das Clínicas, da Faculdade de Medicina da Universidade de São Paulo. Inicialmente, quero agradecer à comissão do SLEP pelo convite para coordenar o workshop sobre displasia fibrosa e síndrome de McNeil-Bright. Essas doenças representam um desafio para os endocrinologistas pediátricos. Apesar disso, têm sido pouco abordadas em congressos, especialmente a displasia fibrosa. Por isso, parabenizo a comissão organizadora por ter incluído estes temas. É uma honra eu apresentar a vocês a professora Alison Boyce para este workshop. A professora Alison Boyce é endocrinologista pediátrica, chefe da Unidade de Distúrbios Osteometabólicos do Instituto Nacional de Pesquisa Dental e Crâniofacial, dentro do NIH. A professora tem caracterizado diversos aspectos dessas doenças, como a neuropatia óptica, a perda auditiva, o acometimento testicular e a secreção excessiva de hormônio de crescimento e suas consequências. Em 2015, em Oxford, foi formado um grupo para o desenvolvimento de normas para a displasia fibrosa e síndrome de McNeil-Bright, envolvendo diversas especialidades médicas, odontologistas e representantes de pacientes. A professora Boyce é atualmente presidente do Comitê Consultivo Médico da Aliança Displasia Fibrosa Síndrome de McNeil-Bright. Este comitê tem como objetivos aprimorar o cuidado clínico dos pacientes, com foco no diagnóstico precoce, na caracterização da extensão da doença e seu tratamento e monitoramento. Professora Boyce, muito obrigado pela presença neste SLEP e a oportunidade para conhecermos melhor a displasia fibrosa e a síndrome de McNeil-Bright.
Thank you very much for this invitation to present on this topic. Here are my disclosures. So fibrous dysplasia McCune-Albright syndrome is a complex mosaic disorder of G-alpha-S activation. It can involve any part or combination of the skeleton and many parts and combinations of the endocrine system. This complexity makes FD-MAS a fascinating disorder to understand the effects of G-alpha-S and the interplay between systems where it's involved. However, it also makes this a very challenging disorder for clinicians who have the difficult task of diagnosis and management in a disorder where no two patients look alike. FD-MAS arises due to gain-of-function mutations in the alpha subunit of the GSG-coupled protein receptor. In the mutant receptor, loss of the alpha subunit activity leads to constitutive receptor activation. And inappropriate constitutive signaling through the receptor leads to the clinical features of the disease. For example, constitutive signaling through the melanocyte stimulating hormone receptor leads to skin hyperpigmentation. Constitutive signaling through the LH and FSH receptors lead to precocious puberty. Patients may develop excess thyroid hormone, growth hormone, etc. An inherent feature of FD-MAS is that it's a mosaic disease. Mutation is only present in certain numbers of cells, and this is apparent in the clinical features of the disease. The skin pigmentation occurs in a very characteristic distribution along the midline of the body with these jagged, irregular appearing borders. This follows along a pattern called developmental lines of Blaschko, or patterns of early embryonic cell migration. The bone lesions occur in a patchy mosaic distribution and can range anywhere from trivial disease affecting only one or a few bones to severe disease affecting nearly the entire skeleton. The endocrine involvement can also be patchy and irregular, as seen here in this patient who has unilateral testicular involvement. A key feature of a mosaic disorders is the fact that FD-MAS has never been shown to have a case of vertical transmission. So this is not an inherited disease, and it's not passed from parent to child. This probably reflects the fact that germline mutations in G-alpha S are lethal, and these mutations therefore survive through mosaicism. And this image shows our current understanding of FD-MAS pathogenesis. Very early in embryogenesis, a mutation occurs by chance. And the progeny of this mutated cell then spread throughout the developing embryo, forming tissue that will ultimately be affected by disease. When we have a patient who has a phenotype involving disease in tissues that are derived from all three germ layers, i.e. the ectoderm, mesoderm, and endoderm, comprising the bone, skin, and endocrine systems, we know that by necessity, the inciting mutation had to take place very early, prior to gastrulation. Therefore, the map of affected tissues is charted very early in utero, prior to birth. In bone, G-alpha S is a key signaling protein that controls cellular differentiation. So the diseased cell is the skeletal stem cell, also called the skeletal progenitor cell. Under normal circumstances, this cell is a multipotent stem cell that differentiates along a number of different lines, including into osteoblasts, chondrocytes, adipocytes, and hematopoietic supporting cells. In the mutant cell, this differentiation process is blocked, and the cells instead form abnormal osteoblasts. It's proliferation of these abnormal osteoblasts that lead to the histologic features of FD. So we see in FD tissue, unlike normal bone, where you see good lamellar bone and normal marrow structures, all of that architecture has been lost. Instead, the marrow is filled with this fibrous tissue that's poorly differentiated, which represents sheets of these proliferating skeletal stem cells. We also see formation of large areas of abnormal bone. And this is called woven bone, which is an immature type that should only be seen during fetal development and wound healing. We also see very poor mineralization with presence of large areas of unmineralized osteoid. Most of the data I'm going to show today comes from our ongoing natural history protocol at NIH. This is a longstanding study in FD-MAS that has collected standard sets of data elements and clinical specimens in a prospective manner, with the goal of going back and doing retrospective analysis that will define the natural history and spectrum of the disease, establish standard of care, and hopefully identify novel therapeutic targets and surrogate outcome measures. It's been a productive study with up to 300 subjects covering a large age range and up to 25 years of follow-up. And this really messy, complex diagram shows our standard approach to data collection on the natural history study, where patients report to the clinical center on a Monday, undergo standard set of evaluations, and are discharged at the end of the week. So the phenotype of fibrous dysplasia depends quite a bit on which area of the skeleton is involved. And for practical purposes, it's useful to divide the skeleton into three main categories: the craniofacial skeleton, comprising the skull, the axial skeleton, comprising the spine and ribs, and the appendicular skeleton, comprising the limbs. In the skull, most complications of fibrous dysplasia arises due to its tendency to expand. So we have overgrowth of skull tissue, which can lead to facial asymmetry, and in rare cases, functional problems. We can have expansion into the nasal cavity, leading to nasal obstruction. We can have malocclusion of the teeth. And some of the more serious complications can include compression of the optic canal, leading to vision loss, and compression of the hearing structures, leading to hearing loss. In the axial skeleton, the most common complication is scoliosis, or curvature of the spine. This is very common in FD, and in rare cases can actually be progressive into adulthood, and if severe, can be lethal, leading to compression of the lungs and pulmonary failure. Fortunately, this is a complication of FD that responds quite well to surgery, as you can see here in this patient who has had spinal fusion surgery. In the appendicular skeleton or limbs, most of the problems in FD due to its tendency to deform and break under weight-bearing forces. This X-ray here shows a lesion in the proximal femur with very classic radiologic features, including ground glass smooth homogeneity. It's a very lucent lesion without a lot of mineralization. And you can see that it's developing a classic deformity, a coxavera deformity, which we sometimes call a shepherd's crook. This can lead to pain and impairment in ambulation. One early observation we made on our natural history study is that there's a key age-related phenotype in FD. I shared a few slides ago that the mutations that cause FD are acquired very early prior to birth. However, bone development appears to proceed overall pretty normally in children with FD, and there's no obvious evidence of bone disease at birth. This is because it takes time for those mutation-bearing skeletal stem cells to divide enough to form a discrete lesion. So we see that in this graph, the amount of FD that a patient has increases dramatically over the first few years of life, continues to progress throughout skeletal growth, and reaches its final amount in early adulthood. So by the time a patient is 15 years old, we shouldn't see new lesions forming, and we shouldn't see existing lesions progressing. However, if we limit ourselves to clinically significant FD, so this is FD in locations that you care about, like the skull, the proximal femurs, and the spine. If we look very early by age 5, we can see some evidence of those lesions in some form in nearly all instances. So here's a sodium fluoride bone scan in a 5-year-old, and you can see there are small lesions present in some of these areas. They may go on to progress. However, they will be existing in some form by this age. We also see an age-related phenotype in adults. FD activity tends to decrease over time in older individuals. We know this because we see a decline in serum bone turnover markers over time. We can also see partial normalization or improvement of the histologic features of FD if we do biopsies of lesions in patients greater than age 35. This probably reflects the fact that the mutation-bearing skeletal stem cells have a limited lifespan, so they overgo senescence or apoptosis over time. So patients will continue to have clinical complications of FD, however, their lesions become less active. So this shows our current approach to clinical screening in a patient with known or suspected fibrous dysplasia, and it depends quite a bit on age. In all patients, we start with a targeted history and physical exam, looking for signs of skeletal disease, such as fractures, pain, deformity. In patients less than 5 years old who have a low clinical suspicion and no obvious signs of bone disease, they can be monitored clinically. In patients less than 5 years who have clinical signs of bone disease should undergo a skeletal survey or X-ray imaging, should have their hearing and vision checked due to possible skull disease, and should have a serum phosphorus measured. In patients who are greater than 5 years old, we recommend doing a screening nuclear medicine bone scan. This can either be a technetium-99 scan or a sodium fluoride PET-CT. We see abnormal tracer uptake that is indicative of FD, and we recommend following those lesions with more targeted imaging, such as a skeletal survey or a head CT for patients with craniofacial FD. We also recommend checking a serum phosphorus level. If by age 5 years or older, a patient has a normal nuclear medicine bone scan, then that is a very low risk patient, unlikely to ever develop any FD, and can just be monitored clinically without need for routine further imaging. Management of fibrous dysplasia currently is mostly surgical. And in the appendicular skeleton, this is often a very problematic, clinically significant area. Surgical indications in the appendicular skeleton include pain with weight bearing. If a patient is consistently, when they walk, experiencing pain in a very specific area, that's a sign that a fracture may be about to occur and is an indication to go ahead and stabilize that lesion. Also, any deformity that impairs the gait or any progressive femoral neck shaft deformity, less than 110 degrees or greater than 150 degrees. We typically avoid techniques that are effective in many other types of rare bone disease. Unfortunately, curettage and grafting, plates and screws have suboptimal outcomes in FD. We typically prefer intramedullary rods. In the craniofacial skeleton, surgery should really be limited to patients who have functional impairment from their lesions. We only recommend performing surgery for facial asymmetry or for cosmesis if it is severe and debilitating. And the reason for this is that surgical outcomes in the skull tend to be very unsatisfying. If an FD lesion is shaved down or partially removed, there's a very high likelihood that it will grow back on the order of 60 to 85%. So we only want to operate when absolutely necessary in this area. What about endocrinopathies? This is a very important feature to evaluate for and screen for and treat, because endocrinopathies are one of the key risk factors that can increase skeletal morbidity in patients with FD. Patients who have hypophosphatemia have earlier fractures and more frequent fractures. We've shown that patients who have hyperthyroidism and hypophosphatemia are more likely to have progressive scoliosis. Patients with hyperthyroidism and hypophosphatemia are also at risk for skull-based deformities, in this case, basilar invagination, where the cervical vertebrae becomes displaced through the foramen magnum, which can lead to neurologic problems. And in the skull, growth hormone excess leads to craniofacial expansion, which increases the risk of vision loss and hearing loss. And I really wanted to emphasize this effect of growth hormone excess on craniofacial FD, because it's really serious, and it's also an area where we've shown definitively that early intervention can prevent morbidity. So these are two patients here who have equal severity of growth hormone excess and have equally severe craniofacial FD. This patient at the top was diagnosed with growth hormone excess at age 9 and started on treatment right away. And you can see that her skull is overall fairly symmetric. She has patent optic canals and normal vision. This patient on the bottom, unfortunately, was not diagnosed with growth hormone excess until age 18. So you can see his skull has really undergone massive overgrowth, particularly here in the jaw and the maxillary areas. And on CT scan, we can see that his optic canals have become occluded, so he is now blind. Hypophosphatemia and FD is an area where study of this rare disease has really informed our understanding of normal physiology. So early on, it was noted that only patients that have a lot of FD will go on to develop hypophosphatemia. And this is because FD tissue produces FGF23, the phosphaturic hormone. So we see a linear relationship between the amount of FD that someone has and the amount of FGF23 that is present in their blood. And it was this recognition that fibrous dysplasia is the pathologic source of FGF23 in our patients led to studies in normal bone and confirmed that bone is indeed the tissue source of FGF23. So one clinical consequence of this is that FGF23-mediated hypophosphatemia and FD will often show up during periods of rapid growth. So in times when a patient needs more phosphorus, such as infancy and adolescence, it's pretty common to see hypophosphatemia become unmasked during those times. Hypophosphatemia can also wax and wane depending on how active FD is, and it's quite common for the phosphorus levels to improve in adulthood. So I want to briefly touch on therapies for FGF23 excess, and probably most of this audience is familiar with these. The most standard therapy in fibrous dysplasia right now is what we call conventional therapy. So this is treatment with oral phosphorus given 3 to 5 times per day and active vitamin D analogs like calcitriol or alpha calcidiol. So this therapy is pretty poorly tolerated. It's associated with a high risk of GI and kidney side effects. There's a new targeted therapy called burosumab, an anti-FGF23 antibody, which has been approved for treatment of X-linked hypophosphatemic rickets and tumor-induced osteomalacia, which are both disorders of FGF23 excess. In these disorders, burosumab is very effective at correcting hypophosphatemia, including improving physical function and healing fractures. It's a very safe therapy. However, it's very expensive, currently costs about $200,000 a year. And importantly, it's not been studied or approved in patients with FD. So at NIH right now, we are developing a clinical trial of burosumab to study its use in FD. Our main objectives are first, safety. We want to see if burosumab has any inherent effects on the FD lesion activity and on the activity of those mutation-bearing skeletal stem cells. We also are interested in looking at efficacy. I'm particularly intrigued about the possibility of burosumab increasing serum phosphorus levels up into the middle of the normal range, or even the upper part of the normal range. This is something that's typically not achievable with conventional therapy. So just to sum up what I've shared about endocrine disease, this is our current approach for screening and monitoring in patients with known or suspected MAS. We always start with our history and physical exam, including to look for clinical signs and symptoms of endocrinopathies, including reviewing a growth curve. We recommend routinely checking labs in all patients at their initial visit, including thyroid function tests, IGF-1, and a serum phosphorus. We also recommend routine imaging in all patients with known or suspected disease, to include a bone age, a thyroid ultrasound, and a testicular ultrasound. If all of this is normal, then we recommend ongoing monitoring, particularly for pediatric patients. So this should include continuing to monitor growth and physical exam. The only patients that need to undergo routine laboratory monitoring are in a few scenarios. If you have a patient with craniofacial FD, you want to continue to monitor IGF-1 levels because sometimes growth hormone excess can show up late. I've seen it present as late as early adulthood. In young children under age 10 who have abnormal thyroid ultrasound but normal thyroid function tests should continue to have their thyroid function monitored. Again, I've seen hyperthyroidism show up late, kind of as early as late childhood. And patients who have polyostotic fibrous dysplasia should continue to have their phosphorus levels checked. However, we don't recommend any routine imaging for after screening. Switching gears a bit to talk about pain. Pain is a big problem in fibrous dysplasia that a lot of clinicians and patients struggle with. And this is some survey data from our natural history study. And a few points I'll emphasize is that we see that overall mean pain scores are higher in adults than children. So pain seems to increase over time. However, if we look at the patients that have pain, children are much less likely to be receiving any pain medications. So we think pain is certainly possibly present in children and is likely undertreated. Most patients who tried bisphosphonates reported that it was effective for pain relief. Interestingly, there's no correlation between the amount of fibrous dysplasia that someone has and the amount of pain that they have. We see patients here who have very high disease burden scores, meaning most of their skeleton is involved with FD and they have no pain. On the other end, we have patients with very small lesions who present with a lot of pain. Interestingly, there seem to be several different types of pain that might be present. Patients who report neuropathic type pain, meaning pain that has features of nerve-like pain like stinging, numbness, tingling, overall report higher pain levels and more functional impairment. So there's a lot of questions that still have not been answered about fibrous dysplasia pain. We don't understand its mechanism. We don't understand this potential nervous system component. And the age-related changes are puzzling because we see pain increase just at the time that fibrous dysplasia activity decreases. So future research is needed to understand these questions and to define the optimal treatment. This is our current approach to pain management in patients with FD. If pain is focal, meaning it occurs in only one spot, or acute, so it had an onset, relatively recently, it's important to evaluate for orthopedic problems, such as a current or impending fracture, an aneurysmal bone cyst, or other orthopedic issue. If pain is diffuse, meaning it's present in multiple areas of the body, or chronic, it's been going on for more than 6 to 8 weeks, you want to think about hypophosphatemia. That's often how it presents. If phosphorus is normal, you can try NSAIDs and supportive care. And we reserve bisphosphonates for use in patients who have persistent, moderate to severe pain. And I'll talk a little bit about that in the next few sections. Now I'm going to switch gears and talk about our attempts in our research at NIH to identify therapeutic targets and new treatments in FD. Our approach grew out of this observation that FD lesions are in a state of high bone remodeling. So you can see that clinically because patients have high bone turnover markers in their blood, and these bone turnover markers parallel the amount of disease that patients have. It's also quite apparent in childhood because lesions are expanding and invading normal areas of bone as the FD lesions expand. Histologically, we see evidence of high turnover in these large areas of abnormal bone formation and then very prominent osteoclastogenesis. So this is a state where bone is being formed and broken down quite rapidly. That led us to ask, could anti-resorptive medications targeting this osteoclast activity be an effective treatment strategy for FD? Most here are probably familiar with bisphosphonates. Just briefly, these are analogs of the protein pyrophosphate. They are taken up into the skeletal matrix where they inhibit osteoclast activity, and they have been used for decades to treat disorders of either low bone mass or high bone turnover, such as osteoporosis and skeletal metastases. So we performed a randomized placebo-controlled trial using the oral bisphosphonate alendronate in patients with FD. This is still the only reported placebo-controlled trial that's been conducted in this disease. It included 36 total patients who were treated over a 2-year course. We saw that the serum markers of bone resorption were decreased in the blood in patients on the drug. However, we didn't see any effect on bone formation markers. We did see increased density on FD lesions on DEXA, but only in children, not when we looked at adults or the group altogether. Unfortunately, we didn't see any effect on pain, and we didn't see any changes on clinically relevant outcomes, such as fractures, measures of physical performance, or the radiographic appearance of FD lesions. So based on the pediatric data from the alendronate study, we asked the question, if bisphosphonates are given to growing children, can we prevent new FD lesions from forming or existing FD lesions from expanding? And unfortunately, the answer was no. On a retrospective review, even children treated with very high dose bisphosphonates did not have any difference in FD lesion acquisition. And there was also a study reported by a group at Montreal looking at FD lesion bone biopsies before and after bisphosphonates, which showed no effect on histology or histomorphometry. Concerningly, we have identified multiple cases of osteonecrosis of the jaw associated with bisphosphonate treatment in our NIH cohort. It's occurred in about 5% of bisphosphonate-treated patients. So taking all of this together, we feel that the current evidence really only supports the use of bisphosphonates for pain relief and only intravenous bisphosphonates. There are no evidence to support beneficial effects on bone quality or other skeletal outcomes. And because of the lack of benefit on bone lesions and the potential for side effects, such as osteonecrosis of the jaw, we recommend using the lowest dose and interval needed for bisphosphonates that will achieve symptom relief. So rather than putting patients on a set schedule, we give a dose and then we repeat the next one when the pain relieving effect has worn off. So we tried another strategy to target osteoclasts in FD, and this is through a protein called receptor activator of nuclear kappa B ligand, or RANKL. RANKL is a member of the tumor necrosis superfamily and tumor necrosis factor superfamily, and it's expressed on the surface of osteoblasts and skeletal progenitor cells. It binds its receptor rank on osteoclast precursors and activates formation of mature osteoclasts and bone resorption. And it's regulated through the protein osteoprotogerin, which binds RANKL and prevents its relationship with its receptor. Denosumab, similar to osteoprotogerin, is a monoclonal antibody to RANKL It's been approved by the FDA and other regulating bodies since 2010 for treatment of osteoporosis, bone metastases, and giant cell tumors. We have a growing body of evidence that rankle seems to play an important role in FD pathogenesis. We see increased rankle levels in the blood of patients with FD, and these levels parallel the amount of FD that someone has. In FD tissue, we see high rankle expression, and the areas of expression seem to correlate with areas where the skeletal progenitor cells are more proliferative and more active. FD cells secrete rankle, and in vitro, when co-cultured with pre-osteoclastic monocytes, are able to support formation of mature osteoclasts. There's also animal data supporting a role for rankle. This is a mouse model that was developed by Mara Ruminucci in Italy. And these transgenic mice express the G-alpha-S R201C mutation. In these mice, treatment with an anti-rankle antibody led to new bone formation within FD lesions, increased mineral content, and improved biomechanical properties. After treatment was discontinued, these lesions recurred and new lesions formed, supporting the fact that these effects are transient. So based on this data, we are nearing completion of a pilot study of denosumab treatment in adults with FD. This is an open label study that's conducted with a 6-month treatment period and a very long post-treatment discontinuation period to watch what happens after denosumab is stopped. The endpoints on this study is completed its enrollment and will be starting formal data analysis probably in the next 1 to 2 months. Primary endpoint is bone turnover markers, and I wanted to share this secondary endpoint, which is shown to be quite useful. These are sodium fluoride PET CTs, which are a combined anatomical and functional imaging modality where patients are injected with the sodium fluoride radioactive tracer, and the tracer goes to areas of the skeleton that have higher uptake, consistent with FD lesions. We can actually quantify the amount of uptake that goes to FD lesions, which correlate with bone turnover markers, and also encouragingly strongly correlate with clinically meaningful outcomes, such as fractures, surgeries, and ambulation impairment. So here's some of our preliminary data from our denosumab interventional study. Encouragingly, we're seeing very nice effects on FD lesion activity on bone scans. And these are just 2 representative patients. This is an adult woman who has very severe FD involvement in her ribs, leading to expansion of these lesions. They've collapsed in and have compromised her lungs. So she has severe restrictive lung disease requiring continuous oxygen support. After starting denosumab, we saw that the uptake in her rib lesions decreased dramatically to the same levels of physiologic uptake in normal bone. And encouragingly, she had a very nice clinical response. Her pulmonary function tests improved, and she was able to come off of oxygen. This is a patient with a very active expansile maxillary lesion, which is quite painful, red, and hot. After denosumab treatment, again, the decrease in tracer uptake is really dramatic, accompanied by a clinical improvement. She has no further pain, no further redness in this area. We do see decreased bone turnover markers when patients are on denosumab, but concerningly, we have seen really massive rebound in bone activity when denosumab has stopped. And this isn't just rebound of normal bone, this is rebound of fibrous dysplasia activity. And in one patient has been associated with severe hypercalcemia. Not in this study, but in a retrospective review of clinically treated patients in the Netherlands, they also found a case of osteonecrosis of the jaw. So denosumab, where are we now? What do we do with this exciting but concerning data? So I think the potential for effects on FD lesion activity are really exciting. There are some patients that experience such morbidity from FD, such as the patient with lung disease that I shared, that the potential for a drug to improve and decrease lesion activity is really important and clinically needed. but we have a number of open questions. It's not clear which patients we should be treating. This is such a potent medication, and clearly it is not one that we need to just be giving to all patients with FD. And for how long? If we start treatment, do we need to continue it indefinitely? Is there any safe way to stop it or potentially wean it off? So at this point, I think we need to proceed with extreme caution when we're treating patients who, especially who are young or have significant FD, because these populations have more bone activity and are probably at risk for a more severe rebound. I think we'll probably know a lot more about when and how to use denosumab in FD over the next couple of years. An exciting potential future direction is whether or not we can use denosumab to prevent FD in significantly affected children. So I shared earlier that FD lesions are established in early childhood. I showed this graph where we saw the FD lesions growing and expanding over those early years before reaching their final form in adulthood. So this provides a potential window of opportunity where if we could intervene with a medication to stop FD from expanding, could we really change the natural course and stop these lesions from forming in the first place? And indeed, that is what we seem to be able to do with our mouse models. So anti-rankle treatment in young mice prevented the lesions from developing. I think this is a topic that really needs to be studied safely and in a very thorough way. We have preparatory studies going on now, including natural history analyses in young children to really focus on that period of early FD lesion development, and also to identify biomarkers that will be able to tell us which children are at risk for developing clinically significant FD and which children could benefit from preventative therapy. So thank you very much for the opportunity to present on this. And I'd like to thank the NIH for supporting this work and my team for all of their hard work on these studies.
Professora Alison Boyce, muito obrigado pela sua apresentação, pela sua palestra. Foi realmente muito esclarecedora. E agora há um espaço para perguntas, onde os participantes deste workshop terão a oportunidade de esclarecer dúvidas com a senhora. Muito obrigado. Professor Alison Boyce, it's a pleasure again. Thank you very much for your lecture. I think that fibrous dysplasia is not commonly discussed in the meetings, although it's a difficult disease to deal with. And your lecture was really very important for us to understand better this disease. I would like to begin asking you a question. We realize that many patients with fibrous dysplasia, they have pain, but not only pain. Many times they do not feel safe to walk. And when we treat with pamidronate, we can realize that they feel much better with respect to this aspect. They feel much more safe to walk. And we have been using pamidronate in cycles of 3 days each 6 months. And what I have realized, Professor, is that the bones that are not affected, they may show a phenotype of high bone mass. And what do you recommend? For how long should we treat these patients with pamidronate? And is it a problem if other bones show a high bone mass phenotype?
No, that's a really excellent observation because one thing that I think is important to keep in mind when you have a patient with fibrous dysplasia is there are two types of bones. So, you have FD bone and normal bone, and any treatment you direct at the FD bone will also impact the normal bone. So I think you're absolutely right. With long-term bisphosphonate users, we can see high bone mass developing. I've also seen a few cases in children who are growing that get lots and lots of bisphosphonates, that they can get modeling defects, very subtle ones at the growth plates. So I think this is one reason it's really important to try to use the lowest dose that you can get away with to improve their pain, and also the longest dosing interval. So what we typically will do is, give a dose pamidronate or zoledronate, and then just observe the patient and see how long the pain effects last, and then give the next dose at that point, rather than doing a set structure. So for your patients, I wonder if you might try doing just a 1-day infusion of pamidronate and see how they do. You can individualize the regimen based on how the patient responds. In particular, some patients have panostatic fibrous dysplasia, and we don't have to worry about high bone mass. But we do have to worry about osteonecrosis of the jaw and other complications. So I think just the lowest dose and the longest interval you can manage is a good approach.
Okay, thank you very much. I have here some questions. Hamilton Cassinelli from Argentina, he's asking, when fibrous dysplasia affects mainly the skull with low pain and moderate affection of nerves, in your criteria, which the major option of treatment?
Yeah, it's a good point. The skull fibrous dysplasia can behave very differently than fibrous dysplasia in other locations. So I think the answer to this question depends a lot on what they mean about affecting the nerves. Fibrous dysplasia very commonly will wrap around nerves and occur in location where nerves are present. The most famous example is the optic nerves, because fibrous dysplasia most commonly is seen in the skull base. The optic canal, which is the tunnel that the nerve travels through to connect the eye and the brain, is involved in probably most patients with craniofacial FD. What's interesting about fibrous dysplasia, though, is even when it occurs around nervous structures, it very rarely causes problems with the nerves. Most of the time, it doesn't tend to expand so aggressively that it pinches the nerves or causes a neuropathy. It is possible to see that, but I would say that's definitely the minority of patients. So I only think treatment for skull FD is indicated if you see the nerves being affected in a way that their function is disrupted. So we see a true neuropathy, like loss of vision from optic nerve neuropathy or a trigeminal neuralgia. In those instances, the treatment is going to depend on which nerve is being affected. If we have true aggressive FD expansion that can't easily be addressed by surgery, that might be a time I would consider denosumab, because I do think denosumab shows it might be able to prevent FD from growing. But as I shared in my talk, I think it's worth being very careful who we start on that medication, because we don't know what will happen when we stop it.
Okay, thank you. Professor, you have been interested in the characterization of GH excess in patients with McNeil-Bright syndrome. When do you think that we should study better if there is a hypersecretion of GH in patients with McNeil-Bright syndrome?
Mhm. Yeah, no, good question. I think everybody who has fibrous dysplasia in their skull should have an IGF-1 checked periodically, particularly if there's a lot of skull FD. And the reason is that growth hormone excess is one of the hormone problems that isn't always present early. It can develop over time. So I've actually diagnosed growth hormone excess even into patients in their 30s. I think when we see that, I think if you actually could go back in time and look very closely at growth hormone secretion dynamics, probably they will be abnormal from birth in any patient with growth hormone excess. But what we see sometimes in patients with MAS is that the growth hormone production is abnormal, but not always bad enough to raise the IGF-1 up. So sometimes you'll have patients who have abnormal glucose tolerance test and where they don't suppress their growth hormone appropriately, but their IGF-1 is still normal. In those patients, over time, what can happen is the IGF-1 will gradually creep up and they may reach the point where they do require treatment. So I think it's easy enough to just check an IGF-1 periodically in anybody that has enough skull FD that you wouldn't want to miss it if they did get growth hormone excess.
Okay. We have here a question of a colleague from Argentina, Hugo Boquet. He is asking what treatment could be used for fibrous dysplasia in young pregnant women with severe bone damage.
Mm-hmm. Yeah, an interesting thing about fibrous dysplasia is that it doesn't tend to be overly damaged or exacerbated in pregnant women. Although there are estrogen and progesterone receptors in FD bone, we don't have any clear evidence that pregnancy will cause bone problems. Now, in patients who have truly severe FD, they like with severe scoliosis or severe pelvic bone involvement, sometimes they can have more complicated pregnancies. In particular, if they have severe scoliosis, that is associated with reduced lung volumes. And in pregnancy, you have further reduction in lung volumes. So that can lead to a complicated pregnancy. And I have seen patients with FD that had to have their pregnancies ended early because the women were having lung problems. But it's a tricky issue. It depends varies a lot from patient to patient. I think a similar situation to this is women with very severe osteogenesis imperfecta. There's a lot more literature describing pregnancy outcomes in those women. And I think when you have a truly severe FD patient, that a lot of the problems they may see in pregnancy would be similar to a woman with severe OI. So I try to refer my patients to OBGYNs that have taken care of other complex bone patients like OI.
Thank you. I have here another question of a colleague from Brazil, Luis Claudio Castro, and he is asking is there any evidence that denosumab has analgesic effects as bisphosphonates have?
Yeah, very good question. And I don't think we really know yet. I can share at least my sense from treating patients on our denosumab trial. Some of the patients who had really high bone turnover markers, when they were treated with denosumab, they did experience some benefits. However, a lot of patients who have FD pain don't necessarily have high bone turnover markers. There really isn't a good relationship with how active your FD is and how much pain you have. So I would consider denosumab for pain treatment if someone has truly debilitating pain and very high bone turnover, but I would be less excited if they did not have high bone turnover. We really need a placebo-controlled study to answer that is the problem. And I don't know if we're ever likely to get that in FD.
Thank you. There is another question from Ana Carolina from Argentina. I think that she wants to know if the patients with high stature or with precocious puberty, if these conditions may worsen the fibrous dysplasia lesions.
So does precocious puberty increase the growth of the FD lesions? Is that the question?
Yes, yes.
Okay. Yeah, I don't think we know. That is something I think about a lot. It's a very good question. We know that the FD lesions grow during childhood around the same time that children are growing, and the FD lesions stop growing in adulthood when growth is done. But we don't really understand what controls that, whether or not that's related to the processes that impact skeletal growth in general, like growth hormone, precocious puberty, all of the signals that cause kids to grow. So don't know for sure. My sense is, though, I suspect probably not, because I haven't observed a big difference in adults who have high estrogen levels versus the ones who don't have high estrogen levels. They don't seem to have more FD problems or more issues. So I don't think precocious puberty exacerbates FD, but we can't know for sure, especially if it's uncontrolled precocious puberty and kids are growing quickly.
Okay. Professor Anderson, it seems that in the case of fibrous dysplasia, there is an increased bone remodeling, and it may be associated with increased action of interleukin 6. Do you think that is it possible to think in any kind of treatment aiming to this increased action of interleukin 6?
So you mean for IL-6, interleukin 6?
Yes.
Yes. Yeah, no, there was a lot of excitement about IL-6 because in vitro studies showed that FD cells seem to overproduce this in addition to some other cytokines. And IL-6 can be targeted with a drug, tocilizumab. And Roland Chaperlat, an investigator in France at Lyon, has completed a placebo-controlled trial of tocilizumab in patients with FD, looking at both pain and bone turnover markers. And the study has not been the study has not been written up yet, but he did present some data at ECTS last year, and unfortunately it was negative. They didn't see any benefit from tocilizumab. So I just said we probably won't get a placebo-controlled study for denosumab, but I have to give credit to Dr. Chaperlat because he did do a placebo-controlled study with tocilizumab. Took many years, but yeah, unfortunately those results were disappointing. There are a number of cytokines that seem to be overproduced in vitro in FD, in patients with FD in cells, also some in the blood. So I think it's possible there might be other cytokines or other inflammatory targets we could think about. But right now, there's not a really obvious targetable one since the tocilizumab study was negative.
It seems that there are no more questions at this moment. Professor, another question, please. When we want to evaluate which bones are affected, we have routinely performed an scintigraphy with technetium of the whole body. Do you think that is it a good strategy to evaluate which bones are affected?
Yes, I do. I think getting a scintigraphy scan at least one time is important for all patients to understand that exact question, which bones are affected. I recommend doing it at age 5 or older. And the reason we have to do a nuclear medicine scan is that if you just get x-rays, you'll be able to see FD in the long bones, but you will not be able to see it in the skull. And you probably won't be able to see it very well in the spine or the ribs. So our usual approach is to get the scintigraphy scan at age 5, then know for sure where there is FD, where there isn't FD. And then based on the scintigraphy scan, then get targeted imaging where you see FD. So get x-rays to look at long bones and get a head CT to look at the skull.
Okay, Professor, I thank you in the name of SLAP for your very kind participation. It's very important for us to this opportunity to discuss with you some very important aspects of fibrous dysplasia. And really it was very, I am very thankful you for your participation in this working group. Okay.
Well, thank you very much. It's really an honor to be included. So it's been my pleasure.